This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Croatian Medical Journal, published in 2026. It's a volumetric MRI case report that explores craniospinal cerebrospinal fluid volume changes after extreme bilateral frontotemporoparietal craniectomy and subsequent cranioplasty.
This is a particularly interesting case, Alara, because it touches on something we see often in the trauma bay, but rarely quantify so precisely: the sinking skin flap syndrome, and how restoring the rigid boundaries of the skull fundamentally changes neurofluid dynamics across the entire craniospinal axis, not just the head.
Exactly. The study follows an 18-year-old woman who sustained a severe traumatic brain injury after being hit by a tram. Initially, she had a left frontotemporal-parietal, or FTP, acute subdural hematoma, and extensive fractures. She underwent an emergency left-sided decompressive craniectomy. But as often happens with these high-energy traumas, a follow-up CT the next day showed a new 20mm thick right-side epidural hematoma.
So she ended up with a bilateral FTP craniectomy. That leaves a massive skull defect. The paper describes it as extreme. In the postoperative period, she developed that classic sinking skin flap, which we know is driven by atmospheric pressure, essentially collapsing the cranial compartment because the normal pressure-volume relationship is gone.
Right. The authors mention that this development suggests the bone defect itself becomes an independent pathophysiological factor, even when intracranial pressure is technically normal. What makes this report unique is that they didn't just look at the brain, they performed full neuroaxis 3D craniospinal imaging before and 3 months after her elective bilateral cranioplasty, using custom implants.
Let's talk about those volumetric findings, because the numbers are quite striking. Alara, walk us through the pre-cranioplasty baseline.
Before the cranioplasty, while she still had the bilateral defects and the sinking skin flaps, her cranial CSF volume was measured at 100.8 milliliters. Her spinal CSF volume was 78.2 milliliters. That gave her a total craniospinal CSF volume of 179.0 milliliters.
And then 3 months after they put the custom plates in and restored the closed box of the cranium?
The change was significant. Her cranial CSF volume jumped to 152.7 milliliters. That's over a 50 milliliter increase in the head alone. But interestingly, the spinal CSF volume also increased to 91.1 milliliters. Total craniospinal CSF went from 179 milliliters to 243.7 milliliters.
So a total net gain of 64.7 milliliters of CSF. That is a massive volume shift. And the paper notes there was no relevant change in the volume of the brain parenchyma itself, right?
Correct. The brain volume stayed stable. This wasn't a case of the brain shrinking to make room for more fluid. It was a global redistribution and expansion of neurofluids within the craniospinal axis once those cranial boundaries were restored.
This is where we need to dive into the why. For our residents listening, we're all taught the traditional model of CSF. It's produced in the choroid plexus, it circulates unidirectionally through the ventricles, and it's absorbed into the durovenous sinuses via arachnoid villi. But the authors of this study argue that these volumetric findings are hard to explain with that old active secretion and unidirectional flow model.
Precisely. They point toward the Bullitt-Klarica-Oreshkovich hypothesis. This contemporary view suggests that CSF, intravascular fluid, and interstitial fluid, or ISF, actually form a single hydrostatic and osmotic capillary-driven system. In this model, fluid is filtered and reabsorbed along the entire craniospinal axis, not just at specific points.
It's a shift from a plumbing model to a hemodynamic osmotic model. When you have a large cranial defect, you're changing the cranial compliance and exposing the system to atmospheric pressure. The study suggests that the bone defect shifts the intracranial CSF pressure toward atmospheric values, especially when the patient is upright, while the rest of the spinal column maintains its own gradient.
The authors mention that different body positions generate a robust hydrostatic CSF pressure gradient in intact systems. By performing this 3D volumetry, they've essentially provided in vivo support for the idea that restoring the skull doesn't just protect the brain, it resets the entire pressure-volume relationship of the nervous system.
I think it's important for our listeners to visualize the sinking skin flap in this context. It's not just a cosmetic issue. The atmospheric pressure is literally pushing the skin onto the brain because the rigid protection is gone. When you replace that bone, you allow the neurofluid system to expand back to its natural higher volume state. The gain of nearly 65 milliliters of fluid without a change in brain volume suggests the system was underfilled or compressed by that atmospheric pressure while the defect was present.
And the clinical outcome for this patient was excellent. After neurosurgical and neurointensive rehabilitation, she remained neurologically stable. She had no new focal deficits, finished high school, and even entered university.
It's a testament to the importance of cranioplasty. Sometimes we view it as a secondary reconstructive procedure, but this data shows it's a physiological restoration.
The study also touches on how this might help us in the future with the timing of cranioplasty. If we can use quantitative craniospinal volumetry to see how much the neurofluid system is being compromised by the defect, we might be able to better justify earlier intervention in patients with syndrome of the Trephinide.
Definitely. It's also a reminder that the spinal compartment is not an isolated system. Seeing that 12.9 milliliter increase in spinal CSF volume after the cranial plates were put in is a perfect illustration of the craniospinal axis acting as a single unit. You can't change the pressure or volume in the head without affecting the spine.
The authors conclude that these volumetric changes align much better with the concept of neurofluid as a single system governed by capillary filtration and reabsorption rather than the traditional third circulation model.
It's rare to see a case report that challenges fundamental physiological models so effectively using standard, albeit sophisticatedly analyzed, clinical imaging. For the residents listening, the key takeaway here is that decompressive craniectomy turns the rigid intracranial space into a partially open system, and cranioplasty is the only way to reverse those drastic changes in pressure-volume relations.
And that syndrome of the Trephinide is a real, measurable physiological state. The atmospheric pressure-driven collapse is quantifiable.
Well, that's about all the time we have for this episode. It's a fascinating look at the intersection of trauma surgery and fluid physiology.
If you're interested in the math behind the volumetry or want to see the 3D reconstructions, we highly recommend checking out the full paper in the Croatian Medical Journal.
Thanks for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Elia. We'll see you in the next episode.